We are live now, doctor. You can start the session.
So, thank you, everybody, and sorry for the delay. I, Dr. Preeti Kamdar, Secretary of the Maharashtra Ophthalmic Society, welcome you all to this webinar on OCTA and FFA. And it is part of our series of one topic, one webinar, where the speaker who is an authority on the subject is given 30-40 minutes to expand on that topic, which is never given in a regular conference. So it has been very well received. All of our YouTube videos have 1.5 plus viewerships. And today we have another authority on the subject, Dr. Muna Bhende, who's a retinal surgeon from Shankar Netralaya. She does not need any introduction, just her name is enough. And she is one who can tell you in detail on OCTA and FFA. But before her talk, let me invite our president, Dr. Anaga Herur, to just address us. Over to you, Dr. Anaga.
Thank you so much, Dr. Preeti. Good evening to one and all, and welcome to one more episode of our One Procedure Per Month webinars. And I'm really very happy and honored that Dr. Muna Bhende ma'am has graciously consented to address all of us, and I'm sure it's going to be extremely overwhelming for all of us and a lot of learning. So over to you. Thank you so much, Dr.
So,
thank you to all the panelists. Yes.
Our panelists, we have again a star-studded faculty. So Dr. Ashish Vaidya, who's an experienced retinal surgeon from Mumbai. Dr. Prashant, unfortunately, he's traveling, Dr. Bhavan Kule. I think he's also en route Chennai only. So he's not been able to join us just now. He's, of course, the chairperson, ARC, AIOS. Then we have Dr. Rahul Tiwari, who's an experienced retinal surgeon from Nagpur, and Dr. Deepti Kulkarni, who's another experienced ophthalmic retinal surgeon from Meerut. So these are the people who are going to address our questions when we grill them after the end of the session. And my co-host is Dr. Manali Devasthali, who's a retinal surgeon from Mumbai, and Dr. Nitin Prabhu Desai. He's one of the panelists. He's an experienced and senior retinal surgeon from Pune. So without any ado, I will ask Dr. Muna Bhende to please start her talk. But before that, just one clip from Ajanta Pharma. If you can play it, please. Manjula, if you can just play that clip.
Okay, doctor.
Are you playing the clip? Manjula, are you playing the clip?
Opening, doctor, opening.
It should be ready, Manjula. If it's going to take time, then let Madam start her lecture. The clip, Manjula. I think let Dr. Muna Bhende start her lecture, then we'll see. Muna, if you can please share your screen. I'm sorry.
No. So you can see my slides, right?
Not yet. It just says started screen sharing, but we are not able to see this. Yeah, now we are. Yes.
Okay. Good evening, everyone, and thank you, Preeti, and the team from MOS for inviting me. It's a little daunting task to cover these two topics in the allotted time, but I'll try my best to make it as practical as possible. And there are a lot of experienced people on the panel. I'm sure they'll, including my teacher, Dr. Nitin, when I started fellowship. So honored to have him on the panel. So the outline will be the basic principles of FFA and OCTA, classic images of normal and abnormal findings, and maybe a few words on where both are equally informative, where one scores over the other in certain special situations. So why really do we need these investigations? We have the unique advantage of being able to directly visualize the retinal and to some extent the choroidal vasculature in real time. And while structural changes may be evident, it's not always possible to confirm leakage, perfusion, and the existence of abnormal vessels only by direct visualization. And so sometimes we need a contrast agent that behaves specifically in normal and abnormal conditions, which can be captured by photography. And in the retina, we have two dyes, fluorescein and indocyanine green, which give us information about the circulation. Fluorescein angiogram gives us information on the superficial structures of the fundus. It is able to pick up new vessels, areas of non-perfusion, and any abnormality in the retinal circulation, and to some extent on the choriocapillaries. And ICG angiography gives us information on the choroidal structures. This is because they behave differently. And leakage from a blood vessel, leakage of fluorescein indicates that the vessel is inflamed because of breakdown of the blood-retinal barrier. Whereas ICG molecule is fairly large and it shows up better on the choroidal circulation. So basically the principles of fluorescein angiography is when you have light which is emitted in a particular range, it excites the fluorescein molecules, brings them to a higher energy state. And as they decay, they emit light in a different wavelength. So you have two filters, the exciter filter, which is blue, which gives you which causes absorption of the light, and the green filter, which causes emission of the light. And solutions containing fluorescein are easily available. They can be either 5% fluorescein 10 ml or 5 ml of 10% fluorescein, and sometimes 3 ml of 25% fluorescein. The more concentrated solution definitely will give better pictures, but sometimes it goes and sits in the dead space, so you may not get enough dye in the peripheral circulation. And these are basically the equipment and materials needed for angiography. Most importantly, it's an invasive test. So you have to have your crash cart ready and be prepared for any allergic problems. And these are the common side effects and complications of fluorescein injection. If you don't put the needle into the vein, then you can have extravasation, tissue necrosis. If patient is on a full stomach, vomiting, which is why we keep them at 2 hours fasting. Sometimes a vasovagal attack, but rarely severe anaphylaxis. So what are the phases of the normal fluorescein angiogram? This just a little bit of theory, since I understand the audience will be mixed. The first is the choroidal phase, the choroidal filling, which occurs within 10 to 15 seconds of dye injection. And here you see the background patchy fluorescence. That's because of the lobular structure of the choroid. 1 to 3 seconds later, you see the retinal arterial circulation. Here you see the arteries are bright, the veins are still dark. And this is followed by the arteriovenous phase. So first we have the lamellar flow, which is seen in the early arteriovenous phase. Then you have the mid phase where the arteries and veins are equally filled. And you have the late phase where the arteries start emptying out and the veins are better filled. And finally, the rate phase when fluorescein recirculates and you get a faint staining. And you see progressively the disc also becomes hyperfluorescent towards the late stage. So this is basically a theory slide, but one needs to know how fluorescein behaves. So if you have less fluorescence in an area, it could be blocked and it could be blocked by material from the retina or the choroid. It can be blocked by blood. It can be blocked even by anything from the anterior segment, the vitreous, the inner retina, and the choroidal vest structures can be blocked by deep retinal or sub-RPE lesions, most commonly blood. And then you can have vascular filling defects, which could be either retinal, disc filling defects, or choroidal filling defects. And these are the various situations that you can have. So what is the commonest cause of hypofluorescence? It's either a blocked or a filling defect, and this is typically seen in a branch retinal vein occlusion, where in the early stages you have a significant amount of hemorrhage, and this blocks the fluorescence from the deeper layers. Here you see the blocked fluorescence due to the blood and a little bit of late staining. Whereas if you have an old vein occlusion where the blood has all absorbed, then you can see the sclerosed retinal vessels here, and you see there are areas where the dye has not reached the surface, has not reached the vessels at all. So this is a blocked fluorescence, a hypofluorescence due to a filling defect. And sometimes you have conditions like this, where you have a central retinal artery occlusion, but the patient happens to have a cilioretinal artery as well, and fairly well supplied. And you see that the retina is well perfused in the center. And if you look at the fluorescein angiogram, you see that dye has barely reached any of the other vessels, but it is filling the area supplied by the cilioretinal artery. Now, coming to hypofluorescence, you can have pre-injection fluorescence, which is why it's important to have your pre-injection films. And these are typically due to optic nerve head drusen. Our newer machines are quite good, so pseudofluorescence is highly unlikely with the newer cameras. You can get early vascular hyperfluorescence due to abnormal vessels, which could be either retinal or choroidal. And sometimes you can get early hyperfluorescence if there is loss of the pigment epithelium, where you have the underlying choroidal structures seen through. Hypofluorescence can also be late, in which it's due to leakage, and this can occur into the vitreous. Very often we see a patient with proliferative diabetic retinopathy coming to see us after the FFA, and if you look at the whole vitreous, it looks green. That's because of leakage from the neovascularization into the vitreous cavity. An inflamed eye also, the vitreous sometimes looks green after fluorescein angiogram, again due to leakage of dye into the vitreous cavity. Of course, disc leak due to new vessels and disc leak, disc staining due to inflammation are well known. And common causes of leakage from the retinal circulation, cystoid edema and non-cystoid edema. And of course, pooling and staining, where you get fluid leaking from the choroidal circulation. Now, the commonest example, which most of us would see in our clinic for hyperfluorescence, which originates from the retinal vasculature, is diabetic retinopathy. You see this patient with a succinate of hard exudates temporal to the macula, and you see these hyperfluorescent dots all over the posterior pole, mainly concentrated within the succinates. And these are the microaneurysms, which are hyperfluorescent, and we know the vessels are incompetent, and so they leak. And these are the late phase of the angiogram, where you see these bright dots are now become fuzzy, indicating that the fluorescence is leaking from the abnormal structures. And the corresponding OCT shows that due to this leakage, there is thickening of the macula. That was just one form of hyperfluorescence. You also have hyperfluorescence from abnormal retinal vessels, as in this patient who has both leakage from microaneurysms as well as leakage from neovascularization of the disc. So this is a typical case of proliferative diabetic retinopathy with macular edema. And here you see there is non-perfusion as well. There is the honeycomb pattern that occurs in cystoid macular edema because of dye leakage and fluid connection in the Henle's nerve fiber layer. And you see this fuzzy hyperfluorescence originating from the new vessels at the disc. And this is the corresponding OCT, which shows you that there is macular thickening along with other negative biomarkers indicating that the visual prognosis is poor. Now, this is another situation, again, an old retinal vascular occlusion where you have hard exudates and some abnormal microaneurysms here and a sclerosed vessel, indicating that there is ischemia. This photograph also shows you the block. And if you look at the hyperfluorescence here, it's basically due to pre-existing channels which get reopened to bypass the block. Here you see the block and you see channels that are bypassing the block. Again, you see channels crossing the horizontal raphe. These are all collateral circulations, which are a form of compensation for a branch vein occlusion. And these are usually incompetent, though they don't leak as profusely as new vessels. You can sometimes get a little fuzziness in the borders and you get leakage in the area here. There is fluid here. There are microaneurysms which are leaking. So here you are seeing hyperfluorescence due to reopening of existing channels. Another cause of hyperfluorescence is new vessels. Again, I'm using an example of a branch vein occlusion because then you can see the difference between one sector and the other. Here you have non-perfusion. And here you have hyperfluorescence in a lacy kind of pattern, which shows fuzzy outlines, some amount of dot-like hyperfluorescence indicating microaneurysms, and all this happens at the junction of the perfused and non-perfused retina. So your fluorescein angiogram not only tells you there is new vessels, but it also tells you, guides you to the area where you need to do laser. And this is the area where there is non-perfusion. Late hyperfluorescence can occur in cystoid macular edema, as in this patient, where you see the parafoveal network of capillaries leaking, and the typical picture of the flower petal appearance is because the Henle's nerve fiber layer, everything converges towards the fovea. You also see the disc is intensely hyperfluorescence towards the late stages, indicating that this is a patient most likely who has pseudophakic cystoid macular edema, where you have disc staining along with cystoid macular edema and no other retinal pathology that is visible. Now, this is an example of an eye with inflammation. And if you look at this hyperfluorescence, you see there is staining of the vessels. In these areas, there is hyperautofluorescence and fuzziness at the late phases. There is staining of the optic disc, and there is cystoid macular edema. So this is a typical picture of posterior uveitis. You have retinal vasculitis, you have disc leakage, and cystoid macular edema. So we've seen the origin of hyperfluorescence in various conditions, and it's the mix and match that helps you make your diagnosis. And sometimes you can get transmitted hyperfluorescence as well. Here you have a patient with multiple drusen. There are a few hard exudates. There's a little bit of hemorrhage in the center surrounded by a grayish yellow membrane. In the early phase, you see that there is blocked fluorescence. In this area, there is a little network here, a very small network here corresponding to this area here. The blocked fluorescence is because of fluid. And you have transmitted hyperfluorescence caused by the hard drusen. And in the late stage, you see this fuzzy hyperfluorescence caused by leakage from a classic choroidal neovascular membrane. Occult membranes are not very well seen because they are below the RPE and they are better picked up on ICG angiography. A typical example of a combination of both leakage and pooling is central serous retinopathy. Here you have two small areas of dot-like hyperfluorescence that increase in intensity here, and they become more and more fuzzy. And then you have faint late staining in this area. So these are the central serous retinopathy leaks. You have the ink blot and the smokestack. And the reason you get this faint staining or pooling here is because the fluid collects in the neurosensory detachment where the cells are very loosely packed. So you get this kind of diffuse, faint, late hyperfluorescence. Again, this is an example of a patient with central serous retinopathy. You see this area of transmission defects. If you look at a transmission defect, it doesn't increase in size or shape. In fact, starts fading towards the late phases. These are these pigmentary changes here, which are causing the transmission defect. In the center, you have an area of hyperfluorescence, which is fairly intense, but has a little area of blocked fluorescence within it. Remains the same at the end. And if you look clinically, there is a retinal pigment epithelial detachment. So you have pooling of dye within the pigment epithelial detachment, which is more intense. And you have few pigmentary changes on the surface indicating chronicity, and that is seen as blocked fluorescence. On the temporal side, you have a pocket of subretinal fluid and you have this smokestack leak. And here is the pooling of dye within the neurosensory detachment. So because here the spaces are quite large, loosely packed, you see the faint wide spreading of fluorescence, whereas fluid collecting in a tight space like this definitely shows more intense hyperfluorescence. So it's important when you look at these pictures to realize this is the only one that is actually of significance. This is just an old scar, and this is just pooling within a pigment epithelial detachment. So this is what you actually need to concentrate upon. Again, this is hyperfluorescence due to pooling in a pigment epithelial detachment. This is how you see a chronic PED on fluorescein angiogram. You see there's early intense hyperfluorescence that just increases in intensity, but not in the shape. It's a well-defined margins. And on ICG, you can get a blocked fluorescence. This is the OCT of the same patient, showing that it's just a pure serous pigment epithelial detachment. Again, you can get hyperfluorescence or pooling. Here you have multiple areas of pooling. You see this diffuse hyperfluorescence to start with, and then starts collecting in spaces. And few areas of intense pinpoint hyperfluorescence are also noted. The disc is beginning to look hyperfluorescent. This is very typical. These multiple pockets of fluid are very typical of Vogt-Koyanagi-Harada syndrome. And this is the typical lacy pattern of hyperfluorescence that we've all been taught when we were postgraduates, that this is typical of a classic choroidal neovascular membrane. Believe me, it's very rare to see these kind of classic membranes. Most often in the Indian population, the membranes are occult and not easily picked up on fluorescein angiogram, where they may just show a little speckle. But this is a typical classic CNVM with a lacy pattern of hyperfluorescence in the early phases, which increases in intensity, and then you have fuzzy margins because of collection of pooling of dye in the overlying area of fluid. And here is another patient with a pigment epithelial detachment. And if you look here, you see this little tubular structure running from the retina to the sub-RPE space. And the fluorescein angiogram shows you this retinoretinal anastomosis happening here. The ICG shows that it goes deeper. And in the late phase, you see the spheroidal neovascular membrane at the base and pooling of dye in the pigment epithelial detachment. When you have an irregular pooling of dye like this, always suspect that there is a neovascular membrane somewhere. Again, intense leakage from the disc in BKH along with multiple areas of pinpoint hyperfluorescence. And if you look at this multiple areas of fuzziness with disc leakage, you can rule out central serous retinopathy. This is again a patient with a combined vascular occlusion, and you see there is total lack of vascular filling in this area, significant ischemia. This patient had a CMV retinitis and peripheral occlusions as well. An important condition where one looks at differentiating the patterns of hyperfluorescence, which is of importance in management, is a condition like diabetic retinopathy, where very often we are not sure if the patient has IRMA or new vessels. Here you see IRMA in the left eye of the patient. You have multiple areas of microaneurysms here. And if you look carefully here, you see there are some abnormal vessels that are just running between adjacent vessels and not crossing them. Whereas if you look at the right eye, you see the abnormal vessels which are sitting on the surface of the other vessel crossing on either side. So when it crosses on either side, it is new vessel. When it is between two vessels, you see here there's new vessel, and you see here these are IRMAs, which are actually interconnecting channels between adjacent vessels. So obviously patients with IRMA, we just follow them up closely, but patients with new vessels, this is the hallmark of proliferative diabetic retinopathy. You see the fuzziness on fluorescein angiogram, and these are indications for treatment. This is the late phase in the same left eye and right eye. You look on the left eye, there is no leakage from the vessels, but in the right eye, you see there is leakage, indicating that this is active neovascularization. Now, special situations such as this, very often you have non-mydriatic fundus cameras, or you look through an undilated pupil and you think the patient has no diabetic retinopathy. Now, this is a gentleman who just came for his annual retinal examination with no visual complaints, and the fundus showed only a few scattered hemorrhages in the periphery. The posterior pole had barely any changes at all. And if you look here, there are some hemorrhages, few of them white dots as well. And this is where you need the ultra-wide field fluorescein angiogram. And you look that on the posterior pole, there's actually not too much of change. Most of the changes are actually in the periphery. And sometimes when you see a lot of these peripheral changes, we sometimes need to investigate the patient for ocular ischemic syndrome as well. But with the advent of ultra-wide field imaging, we know that diabetic retinopathy need not always be at the posterior pole. It can also be confined to the periphery with the posterior pole looking normal. And if you were to compare these two eyes, and if you were looking at this patient, you would say, I don't need an ultra-wide field FFA, because all the changes are in the posterior pole, which is what we are traditionally taught in diabetic retinopathy. The periphery looks absolutely normal. But contrast it with this patient. If you look at the posterior pole, things look quite okay. In fact, it looks better than this side. But if you look at the periphery, you see there is significant ischemia. So this is one of the benefits we have of ultra-wide field imaging. And we know that even in the most advanced OCTA machines, we are not able to see right up to the aura. This is an example of a patient who had Coats disease and had been getting a follow-up with his local ophthalmologist who just did a direct ophthalmoscopy, and they couldn't explain why he had cystoid macular edema in the left eye when everything looked apparently okay. And then when we did a dilatic fundus examination, you see that a lot of vascular abnormalities in the periphery, and sometimes leakage from the periphery can cause just cystoid macular edema, as in this patient here. And as you treat these peripheral lesions, the cystoid macular edema will disappear. Another special situation where we are increasingly using fluorescein angiogram now is for pediatric cases, especially if we are looking at FEVR or ROP, and it is relatively safe. We do our fluorescein angiogram for very small babies in the theater, but little older children even in the clinic. The safe pediatric doses range from 0.1 milligram to 8 milligrams per kg. And you can get circulation between 4 and 53 seconds, approximately 12 seconds following the injection. And I'll just show you a couple of cases. This is a patient who had the fluorescein angiogram and imaged on the red cam. This is the patient post laser photocoagulation, showing that the disease has regressed well and vessels are growing fast. But if you look at this eye, this is post lens sparing vitrectomy. You see the residual small tag of vitreous tissue, and you see there is some peripheral ischemia, and this patient requires additional laser photocoagulation here. FFA is also done sometimes for children with Coats disease, and this is a child undergoing FFA under general anesthesia, and you see the pictures on the red cam image showing the feeder vessels and the abnormal leakage. Oral FFA also we are able to do it on our machines, and this is especially for children, adults who are apprehensive, patients where IV access is difficult and where you need to do an FFA, you have no other alternative. But it's also where conditions where only late leakage is important and early phases are not critical. So this is a 1-year-old child after oral FFA. You see how you get a fairly good fluorescein angiogram. Here we are not looking at the timing, but here we are looking for persistent vessels and to see whether there are any areas of non-perfused retina that require treatment. So again, a child who had Coats disease and the oral fluorescein angiogram showing very well the abnormal leaking vessels and the cystoid changes at the macula, and the right eye showing a normal vasculature. So now that I've finished with fluorescein angiogram, why are we talking about OCTA? OCTA basically because it's a non-invasive imaging tool and it's an extension of OCT. Basically, it identifies subtle alterations within the OCT signal that can be identified and processed to form a depth-encoded vascular flow map. And basically, one performs repeated scans of the same area, and the signal is different in areas with blood flow, and that is picked up, and you see that as a photograph. So you can get the image at various depths in the vitreoretinal interface, the superficial retinal plexus, the deep plexus, the outer retina, the choriocapillaries, and the deep choroid. So basically, it is based on the principle where the signal changes due to moving particles. And so it detects motion contrast. So it's useful to study the vasculature. So if you look carefully here, these are two OCT beams, which you see A1 going through the artery here. You see this goes right through and you get a standard A scan signal. Whereas here you see the beam hits an RBC. So when it hits the RBC, the signal is different. You get more light reflected back and then you get the signal. So all this is processed and then you get your OCTA picture. It's important because it eliminates the need for an invasive procedure. There is no dye, so no injection-related complications. We all know that timing is very crucial in FFA in most cases, especially if you're looking at choroidal neovascular membranes. If you miss the early phase, you've missed the membrane. Similarly with CSR leaks. So here there is no question of timing, and you can go back and repeat the test as frequently as you like. And there's very limited obscuration of retinal vascular features that may occur with dye leakage. Now, if you look at this patient, it just looks like a multiple central serous retinopathy. And if you see the ICG, you see there are areas of hyperfluorescence. but something a little odd in the macula, but you can't see anything definite. But if you do an OCTA through the same area, then you see there's actually a choroidal neovascular membrane. So especially in conditions like CSR, in atypical situations like elderly people, the OCTA definitely helps us to pick up choroidal neovascular membranes, which require a treatment. Now, how do you read the OCTA? Of course, as in any investigation, the clinical photograph is the most important. And then you decide which is your area of interest and what you're looking for. Because though you may have a wide field OCTA, if you're looking at subtle changes, then your 3 by 3 millimeter gives you the best and the most dense scan. So while wide field may look pretty, if you're looking for small things, then you need a dense small scan. So you need to look, what am I really looking at? Am I just looking at a pretty picture or am I looking for something specific? Then you look at the scan quality and you look for major artifacts, because artifacts are a big thing in OCTA, and I'll speak to you about that shortly. And then you go layer by layer. You look at the vitreoretinal interface, which is traditionally avascular. Then you look at the superficial capillary slab, which represents the retinal vessels, which can also be seen on fluorescein angiogram. The biggest benefits of the OCTA is looking at the deep capillary and the outer retinal avascular slabs. The deep capillary slab is not picked on fluorescein angiogram, and this can be the site of many abnormalities. And the outer retina or avascular slab is useful to pick up abnormal vessels. Similarly, the choriocapillary slab is important in inflammations, and the choroidal slab, we are now seeing an increased role of the choroid in conditions like PCV, conditions like CSCR, and definitely the pachychoroid spectrum. So then we look at the flow signal, we look at the UNFAS image and the B scan, and then rule out other artifacts, and then you form your impression. So this is a typical picture of a 6 by 6 millimeter scan centered at the macula. And here you see there are the various slabs, and what has been selected is the superficial slab. And you see there are all dilated capillaries here. And you look at the UNFAS structure. If you notice, when you look at the vasculature here, you can't see cystoid edema. But you look at the UNFAS here, you see that typical petaloid appearance, indicating that there is cystoid edema. Then you look at your B scan. The B scans show cystoid edema and neurosensory detachment. And all these areas here, you see the bright spots here. These are microaneurysms which are leaking. Sometimes you don't see them too well on the superficial layer. And then you have the various matrices where you can get the measurements of the vessel density, the area of the FAS, the circularity, and the perimeter. So most angioplex metrics right now do not have too much of a role clinically, more of a research tool, or if you want to study progression of disease. And then you can repeat this on the next visit. This is at 2 subsequent follow-ups. You see the eye tracking, so the same spot is selected. And then you can see the differences between exam 1 and exam 2. And then you can see how this diabetic retinopathy has progressed. As I mentioned earlier, these things are very little clinical application currently. They're more in the research tools. Again, it's more important to choose the slab wisely. Now you have this patient with a grayish membrane at the macula surrounded by hard exudates, a few hemorrhages. And then you do your OCTA. And if you look at this, this is not representative of the lesion at all, because if you look at the B scan, the lesion is actually deeper and your segmentation lines are covering the superficial retina. So this looks like a normal OCTA, whereas the problem is actually much deeper. As you go deeper, here, there's nothing much in the OCTA here, but if you look at the UNFAS structural scan, it shows that there are some fluid pockets. And if you look at your segmentation line, you'll see that this line is going through some of the fluid pockets that you're seeing here. And then you go deeper into the avascular slab. Again, nothing much is seen here, but if you look here, you have these circular areas indicating some amount of fluid and some amount of outer retinal tubulations. These are the outer retinal tubulations here, seen as circular structures. And then if you go further deeper, this is actually the area which tells you why the patient has fluid, why the patient has exudate. And this is the abnormal vascular network seen in the outer retina choriocapillary slab. So it's very important that when you see a structure that you do a video, either you scroll through all the layers, or if you have a technician doing it for you, then you ask them to look at that specific area, otherwise you're likely to miss. So its role as a diagnostic tool is actually quite well established. Most importantly, identification of non-exudative AMDs. Neovascular AMD, because we do know in the fellow eye, sometimes you can pick up a small CNVM that does not require treatment, but requires very close follow-up. Preclinical diabetic retinopathy changes, like a small change in the FAS or a few areas of decrease in vascularity. So you can pick that up. An increase in size of a lesion under observation. Very often we just follow patients with a choroidal neovascular membrane that has no fluid and is currently quiet after treatment. But you can use your OCTA to monitor the patient. And definitely you can pick up IRMA, new vessels, and non-perfusion very well on an OCTA. It can give us a clue to disease pathophysiology. And this is important because you can visualize the deep capillary plexus. Because we know now that the early stages of MACTEL starts in the deep capillary plexus. The superficial plexus may look normal. And we are also identifying now lesions like PAM, where you have vascular occlusion again in the deep capillary plexus that cannot be picked up on FFA. And flow deficits in the chorioscapillary slab, which are now known as precursors to geographic atrophy. But it's important to know that even with all our expertise or experience in interpreting OCTA, most treatment decisions rely on leakage on FFA, fluid on OCT, and fluid on the B-scan OCTA, in addition to other clinical signs. So OCTA alone may not tell you which patient to treat, though over a period of time, one can learn that as well. It's also got a significant impact of artifacts, and the most important artifacts are the projection artifacts. Because these can show retinal vessels or retinal vascular structures, or even appearance like new vessels where the structures are actually deeper than or more superficial than where they reside. And this is because of transmission and reflection of the signal through the vasculature, through the tissues deep below that. And one can always interpret it as a vascular flow. Motion artifacts are definitely important because nobody is really going to show you a picture of an OCTA in an uncooperative patient. And uncooperative patients form almost more than 50% of our practice. So whatever I'm showing you here are good pictures of classic cases, but it doesn't always happen because patients need to fixate at a particular point, which is why you need to know where you're looking at. If you ask for a 12 millimeter scan for all patients, they are not going to be able to cooperate. You need to have a small scan exactly that is fast and where they can focus upon. And again, if you don't do your segmentation properly, you can get false flow signals, especially like structures over a pigment epithelial detachment. Now, if you look at these cases, if you are actually going to look at only the OCTA, you would think that this is the patient who has the worst outcome. But actually, when you combine it with the B scan here, you see there's a small network, a small network of vessels here indicating a choroidal neovascular membrane. But if you look at the B scan, there is a lot of fluid indicating that it is active. And if you look at this, what appears to be a large choroidal neovascular membrane, which is true, actually there is no fluid overlying. This is a patient who is just under observation after the lesion has quietened down with injections. So it's not that you ignore this patient, we do need to follow up, but you don't need to treat at this point. And what actually looks like a well-defined lesion, a well-defined choroidal neovascular membrane, is actually a projection artifact. Because if you look here, what the structures have been picked up are actually from the choriocapillaries because the retinal pigment epithelium is lost. So to identify these things and to make your treatment decision, you not only need the OCTA, but you also need a B scan just to make sure that you're not taking a wrong decision. So it's based on ability to image flow, the abnormal presence of flow, absence of flow, and abnormality in the vessel geometry. Now, where do you look for abnormality? If you're looking at retinal vascular disorders, you need to look at the superficial and the deep slabs. If you're looking at choroidal neovascular membranes, you need to look at avascular outer retinal slabs. And again, beware of artifacts, especially projection and segmentation artifacts, and compare it always with the structural OCT to diagnose active leakage. The simplest where you can use the OCTA is to assess treatment response. Here you see a choroidal neovascular membrane surrounded by hemorrhage. The OCTA shows you the typical network of vessels. This is the cross-sectional B scan, which shows you that there is a CNVM. It shows you flow signal indicating they are active vessels. And it also shows you that there is subretinal fluid. And this little halo around it, OCTA is also light, so anything that blocks it can also block the OCTA signal. Here, the block is because of the blood. And this is the patient after an anti-VEGF injection. You know clinically that the patient has done well. And if you look at the OCTA, you see that this membrane has now shrunk. This small halo has become much smaller. And if you look here, the membrane has become more well-defined and now cased within the retinal pigment epithelium, which is very typical of inflammatory membranes and membranes in the young people. But if you look within it, you see there's still flow signal indicating that vascularity persists, and there is a possibility that this membrane can reactivate after a period of time. As I mentioned, we can go at different layers. Here you see a patient where you have a deep neovascular membrane sitting down here. This is a magnified view of it with the feeder vessel. If you look at your B scan, you see the feeder vessel going from the pre-RP to the sub-RP space. And you have cystoid edema and you have a pigment epithelial detachment. And we know that this combination is typical of a type 3 macular neovascularization. It's very difficult to get rid of. And after the first injection, you see that the membrane has shrunk. There is no fluid. But what you need to look at is the presence of this persistent connection between the pre-RP and the sub-RP space that can give rise to reactivation at any time. So with the next injection, you see that this shrinks even further. As I mentioned, nowadays, most of us have patients who have had multiple injections, vision remains stable. So very often, we may not always treat the patient. Here you see this typical picture of a type 1 neovascular membrane. You see this typical medusa head appearance. And if you look at the B scan, you see there is some amount of subretinal fluid. And when you treat the patient, you see this typical conversion to the DED 3 appearance. Here you see these branches with reduced vascularity and the lack of subretinal fluid. And again, this is the other eye of the patient where you see this neovascular network. It is a little thicker than the other eye, but there's no subretinal fluid. This patient we will not be treating, but later on the patient can develop subretinal fluid. You see the membrane configuration has changed again assuming the medusa head appearance, subretinal and intraretinal fluid, and this time the patient requires treatment. So the configuration does give us a clue that the membrane is growing back again, but it's the B scan actually which guides your treatment decision. So in most cases, this is a typical example. Many years ago when I did this patient who had a choroidal neovascular membrane and drusen, we did the FFA and the ICG showing a small CNVM here. And the patient was treated, followed up by OCT showing good regression of the membrane. And then reactivation again. And this is the OCTA image of the same patient. And after a period of time, we moved to monitoring the patient on OCTA. Here you see the membrane, no fluid, so patient was observed. Then the patient developed a small cystoid space at the fovea, was treated, and you see how the membrane has shrunk. And then you see the tip of the neovascular membrane growing again, and then growing again. So you know the membrane is getting reactivated. Look at the B scan, do the B scan through all the areas, and if there is reappearance of fluid, and then we treat the patient. Now, sometimes you need to do an OCTA when patients ask questions, will I lose the other eye? She had lost this eye after VR surgery and came here wanting to know if anything can be done or anything should be done for the fellow eye. She had multiple systemic issues. And if you look at the fundus photograph, you think just background retinopathy changes. This is, I asked for a OCTA montage. And if you look here, like I mentioned, it's not easy to get a patient to cooperate for a white scan OCTA. And this is what I saw. In this picture, there was nothing much except for some peripheral ischemia and one doubtful area here. But this was full of artifacts, movement artifacts and edge artifacts. So then I went and asked for a repeat scan and told the patient that we need to look at these areas again. And when we got the scan repeated, we see there are actually 2 areas of neovascularization in that area that was not picked up the first time. So this patient with neovascularization and peripheral ischemia and the only seeing eye definitely would benefit by panretinal photocoagulation. And there are always questions like sorry?
Sorry, go ahead.
Yeah, okay. There are always questions one looks back and says, did I miss something? And this is one of the cases where one eye was lost due to advanced neovascular AMD and came with a sudden drop in vision in the left eye. And if you look here, there is some grayish appearance and then some retinal hemorrhages. Now, when we see retinal hemorrhages like this, they're very typical of an early type 3 membrane. And if you look at careful OCTA, there is a small neovascular membrane here and cystoid macular edema. These membranes always start intraretinal, that's why you get CME first and then subretinal fluid. And then because we traditionally image both eyes, I went back and looked at the older scans. I thought there was nothing. And then I went more carefully and I looked at the denser 3 millimeter scans, which we were doing as per protocol. And then I found that actually the small membrane had started almost 3 months earlier. You see the flow signal on the B scan. You see this little network that subsequently grew and caused a leakage. And then you have patients like this where they have pigment epithelial detachments and fibrosis here, and you don't know whether it's a type 1 or type 2. It doesn't matter too much. You treat them the same anyway, but we know that the type 1 doesn't go away so early. And this is the typical picture of a patient with a pre-RP membrane and a sub-RP membrane. Here you have two structures, a pre, and you see when you do a careful OCTA, you see that the pre-RP membrane is actually quite small and the sub-RP membrane is very large. This is a typical mixed choroidal neovascularization. And we definitely use the video mode, like you see in this patient whom I had shown earlier. As you follow the video scans lower through the various plexus, you see that the neovascular membrane is now coming into the picture. Now, this is the last part. Where do you need fluorescein angiogram despite managing with OCTA? Most of us in a busy clinic now do an OCTA because it's non-invasive. You don't need an attendant and you can get most of the information you look for. But sometimes you've managed so far with OCTA, you do need an FFA. As in this patient with CRVO, you see responds well to ranibizumab, but you see progressively developing ischemia in the deep capillary plexus. Like I mentioned, that's the only one, that's a benefit of the OCTA. You see there's progressive ischemia developing despite anatomically good result with the injections. And this is what happens after 2 ranibizumabs. You find that there is a significant ischemia and you keep treating the patient, things get better. And then you get, after 3 injections, more ischemia now visible in the superficial capillary plexus. And now is the time you want to do your ultra-wide field FFA. And that shows you how much ischemia there actually is. And this patient, especially central vein occlusion with so much ischemia, you definitely want to do a PRP. So where are they comparable? So they are comparable if you're looking at changes in diabetics like capillary non-perfusion, IRMA, new vessels, and even sometimes microaneurysms, except in the extreme periphery. And identifying a classic CNVM or a type 2 macular neovascularization, definitely fluorescein angiogram and OCTA are very comparable. Where is OCTA better? Basically, OCTA is better than FFA. Please note, I'm not talking about ICG. FFA does not pick up structures deep to the RP, and that's where OCTA definitely has an edge. OCTA is definitely better to identify the deep capillary plexus lesions like PAM and lesions deep to the RP like type 1 macular neovascularization and PC. And probably the single most important advantage is diagnosis of subclinical choroidal neovascularization. This is the fellow eye of a patient I'm treating for CNVM, and I'm following the other eye where there is a small subclinical CNVM, which causing a little elevation of the pigment epithelium, but no overlying fluid. And we know that until there's fluid, we don't treat these eyes. So this is an elderly lady who had multiple episodes of CSCR and had been treated with everything available. And she came with visual symptoms in the left eye. And this was the right eye. When I did the fluorescein angiogram, it showed a little bit of speckled fluorescence here. ICG also showed a little doubtful hyperfluorescence. A bit of leakage in the late phases. But if you look at the OCTA, you see there's a type 1 choroidal neovascular membrane. This is very typical in central serous retinopathy and in pachychoroid disease. Since there is no subretinal fluid, this patient is just under observation. But where does FFA score over OCTA? Basically, FFA scores because it shows information that is time bound. It shows delayed filling, it shows vascular leakage, it shows non-perfusion, and gives you a dynamic information which currently OCTA does not give. Of course, the role in choroidal neovascular membranes and MACTEL is reduced, but still we require in certain situations. OCTA cannot identify CSR leaks for treatment, and we do know that we need to treat them with focal laser. And definitely FFA ultra wide field is still indispensable in certain cases like retinal vasculitis, pediatric retinal diseases, and diabetic retinopathy. Now, this is the left eye of the lady I showed you earlier with the choroidal neovascular membrane. She had subretinal fluid in the left eye. You see this irregular PED under the SRF and some fuzziness above it. But what the FFA shows us is there's actually a CSR leak in the fellow eye. So the right eye, the OCTA was perfectly fine for us to identify the CNVM, but the OCTA did not pick up the CSR leak in the left eye, which was picked up by the fluorescein angiogram. So very often we need to use a combination of investigations, especially in odd situations, atypical situations like this. So with this I end, and I hope I haven't bored you too much, but I look forward to the discussion. And next week we're having our Retina Summit. So I look forward to seeing some of you there. Thank you very much for your patience.
That was such an exhaustive lecture. Thank you for such a detailed one. And we will have question answers now. But before that, let me just play one clip from Ajanta Pharma, because Ajanta Pharma, they are the people who have sponsored this meetings. They've been very kind to us. And stop sharing. So, Manali, you want to ask the first question?
Okay. Thank you so much, Dr. Bhende ma'am, for such an informative lecture, literally for all of us, I think. My first question to the panel is that in private practice, how often do you do all these three, like an FFA, an OCTA, and an ICG? How often do you do it in a private patient? So we can start with Dr. Prabhu Desai, sir, if he doesn't mind.
Can you switch on your video if it's okay?
Yeah, my video is on.
No, you. Dr.
I'm audible now. I'll start my video also.
Yes. It's yeah. Hi.
Yes, good. So basically, like Octa is basically used to, as Dr. Mona has shown, in AMDs. Like it is mainly used in AMDs for diabetic retinopathies. Usually, we look at the B scan itself. Octa is not really that useful in practical purposes, and for other peripheral diseases, obviously Octa is not so helpful in practical things where we rely more on FFA. But definitely, Octa has made a great difference in management of neovascular AMDs as well as things like MACTEL, where really the initial small lesions, CSR, where you suspect whether it's just pure CSR with fluid or a CSR with an CNVM, there it really makes a difference. So it's a good tool to have, but obviously in day-to-day life, it is you need a combination. You can't just rely on one particular investigation itself.
Thank you. Dr. Ashish, you want to take this? Because this is the most common question asked by people. That when do you prefer Octa? When do you do an FFA? So, and
Yeah,
ICT, of course. So, if you want to take that question, please.
so as Dr. Muna said, it is that sometimes it's a little difficult to get a good Octa image. Now, this happens especially in patients who cannot fix it. So, in patients who have a loss of fixation either because of the macular degeneration or because of diabetic retinopathy, it makes it very difficult to get a good Octa image. When you are seeing something on Octa, you are sure it is there, but then you are not sure whether you are missing something or not. So that's where with something which is very important. Also, in patients who have a very slow leakage, like in myopic patients, myopic CNVMs are very difficult to find, and sometimes they have a lot of retinal pigment epithelial atrophy, because of which there can be artifacts in when you do a Octa. So in something like a myopic CNVM, I would definitely do a fluorescein angiography, and you can pick up the CNVM very nicely a slow leaking CNVM can be picked up very nicely on it. Also in patients with macular ischemia, very often in the central part, you will see a black area. Now, this black area can be because of edema and fluid, or it can be because of non-perfusion. And this makes it very difficult to differentiate. So in almost all my patients, I just get I sometimes don't tell the patient very often that I'm doing an OCTA, but OCTA is still done. I see whether it's giving me any additional information or no. A fluorescein angiography, I do it very rarely today. In fact, if I tell a patient that I'm going to do a FFA for him, he sort of goes into a shock, means he doesn't know why angiography is being done for the eye. Where previously we used to do 10 a day, now I do maybe about 2 or 3 a week, or even less than that. ICG, since I don't personally have it, it's a very rare usage.
So that's very clear what you've said. But many comprehensive ophthalmologists may not have that. As you said, you have the luxury of not telling the patient, but just doing an OCTA. But there are comprehensive ophthalmologists who don't have it and they are going to refer. So that's why, which patients should they refer for OCTA? Like say in Bombay, we have Dr. Deepak Bhatt, who does the OCTA. So now there are some person who don't have it and they're going to refer. So which patients should they refer? That's what
I think, if you're thinking of getting a FFA done, it's always better to get an OCTA done before the FFA. So if you see something, you are definitely able to pick it up and you're able to save an injection to the patient. I mean, intravenous injection to them.
So, Dr. Rahul, in your practice, how much and where do you do the OCTA and FFA?
See, basically the advantage of doing OCTA is that we can see the specific layers of interest. So in practice, for all the AMD patients or wherever we suspect that the macular neovascularization is there, apart from the AMD cases, OCTA is routinely done. Then another benefit is we can repeat it. We can titrate the response to the treatment. So on the every follow-up of these post-injection patients, we do the OCT angiography because obviously FFA cannot be repeated. And as Ashish said, that the need for FFA is basically now reduced. When we plan to do a focal laser, like in case of CSR or a diabetic retinopathy, or in cases where there's ambiguity about the new vessels or the peripheral vascularization has to be checked, these are the patients where we do FFA. Otherwise, we definitely go with the non-invasive modalities before.
So that's Aditi. One question is, at which stage? This is one question asked on the Google form. At which stage of diabetic retinopathy you need to do FFA, or will OCTA suffice forever? That is what one question has been asked. So.
Thanks, ma'am. I think ma'am has already covered all the points that will be a part of this answer. I would like to add one point in the previous discussion also. All these clinical indications apart, there's another logistical issue, small one at the risk of sounding cheeky, that we can have somebody else do an OCTA for us, like an optometrist or a technician. But when we want to do an FFA, especially in a small place, in a small practice, we would want to do it on our own because we don't want to miss any finding. So if you have a long list where you're stuck in the OT, when you're not able to come to the OPD, it's always a safer option to ask them to get an OCTA. And really, if you want to do an FFA, then you have to call the patient when you're going to be available to do the FFA there at that time. At what stage when we have to do an FFA today perhaps is I don't have an ultra wide field or even a wide field fundus camera, but I will do an FFA when I want to see the periphery, because my OCT or OCTA is not going to go up to the periphery. I will do an FFA, move the OCT as to as peripheral part as I can, and then put in that additional jugaad of using your IDEO light to see the periphery in the area that the fundus camera is not going to cover. I mean, this might sound petty, but these are practical problems which I first felt very daunting when I came out of fellowship 10, 12 years back, where there in Retina Institute, we used to do it so easily because everything was there. And what am I going to do with these limited means now? So these points, when I really want to see how the periphery is doing with respect to non-perfusion areas, or are there any lesions in the periphery which look doubtful to me, then I will do an FFA at that time to see what's happening with respect to leakage in those areas.
Okay, sir. So, to give more clarity, which stage? So, all diabetic retinopathies, do you do OCTA, all of you?
Yeah, I will do at the outset, madam, as a baseline.
As a baseline,
For-
you will do OCTA for diabetic
Yeah.
retinopathy.
Preeti, one more thing.
Yeah.
If a patient has a vitreous hemorrhage, which is of unexplained origin, then sometimes, patient, you can't do a OCTA in that. If there's a mild hemorrhage, you can still do a fluorescein angiography and pick up some leakage somewhere. It may not be a very specific leakage, but a fuzzy leakage also can be picked out. And then you can go ahead with the PRP.
Okay, that's a great tip. Manali, you are also just out of fellowship. Even though you are a co-moderator, you are the youngest person in this group. So you tell me, how have you been using OCTA?
No, so I actually don't have access to an Octa as of now. And yeah, even I'm like Dr. Kulkarni ma'am said, even I don't have a wide field fundus camera either. So even I do similar things like see the periphery on the OCT only by positioning and taking the different angles.
Yeah. So those are practical tips, if you don't have those machines, because everything is expensive. So now
Shall I put a point here?
Of course,
Sorry.
please go ahead.
Yeah. See, as compared to in cases of diabetic retinopathy, especially whenever you're suspecting proliferative diabetic retinopathy, I think FFA has no, it's the gold standard. So OCTA may be just helpful for certain things in the center if you want to really differentiate between ischemia and edema when you have to doubt. But in general, if you want to get an overall idea of the circulation, FFA is much better tool at the current stage of practice. Right. So we should not sort of subvert FFA and just rely on OCTA in proliferative diabetic retinopathy.
True. Dr. Munna, you had shown one patient in which there were just 2-3 peripheral hemorrhages, and you went ahead and did an OCTA. That's what I'm asking.
FFA.
2-3.
FFA.
Went ahead and did it. FFA, yes.
Yeah.
So, is that the norm? Because there were just 2-3 for a comprehensive ophthalmologist. I'm a non-retina person. Just seeing 2-3, would you actually do an FFA? What made you do that FFA?
Yeah, okay. You are not going to see only 2-3 peripheral retinal hemorrhages as part of typical diabetic retinopathy. Typical diabetic retinopathy is going to be at the posterior plane. So when you see hemorrhages in the periphery, you always suspect that there is ischemia. And the typical ischemia you get is from an ocular ischemic syndrome. So definitely, and when peripheral ischemia, the risk of neovascularization of iris, angle, etc. is much higher. So when you see more hemorrhages in the periphery, then you would like to do an FFA. And you don't have to do a wide field. You can always do your regular FFA in different gazes. And looking through the indirect, when we were fellows also, we were doing it because at that time we had only 30-degree cameras. So, yeah.
Thank you. And now, if there's a cataract, it's a visually significant cataract. The patient is, say, diabetic. So there also, would you, and you feel that not FFA, it's a visually significant cataract. So which would you prefer, FFA or OCTA? Or OCTA just as a baseline, as Dr. Rahul Tiwari said? Before operating, you want to just make sure that you are not missing something gross. So would you do an OCTA if you see few hemorrhages? Just background diabetic retinopathy is what a comprehensive ophthalmologist will see.
Okay, now if the cataract is visually significant, we need to remember OCTA is also an optical thing.
Correct.
So if the cataract is significant, for one, the patient is not going to fixate well. And the second, you're not going to get good enough pictures. So the chances of you getting a good quality OCTA is very unlikely. In fact, I had exactly the same patient today in my OPD, where there were a few hard exudates that I was seeing more in one eye than the other. I did a B scan, there was some macular edema. And then I did an FFA for her. I did the FFA because I know it will pick up new vessels, even if the cataract is fairly significant. So I did an FFA and there was no new vessel. So I said, okay, go ahead with the cataract and probably give an injection at the same time. So this was my OPD today. So I have a very relevant.
That's exactly what, because I'm thinking from a comprehensive point of view, you all are retinal surgeons, even through a dense cataract or a visually significant cataract will be able to see and pick up lesions. But a comprehensive ophthalmologist may not be. And that's the question that's why I asked. And now one question was, which machine is better for OCTA? So we can, this question will ask all of you. So Dr. Ashish, you already have. So what is the advantage? Why did you choose that machine? You're muted.
Mute.
Yeah, I have a Zeiss machine with which I do the Octa, and I think I was just more comfortable with it. And the post, after you buy the service which is there, and that's the reason why I chose it. The other option is to get the Heidelberg, which is a top-end machine. So I think these are the two machines which normally we would use. Today we have the Dream OCT, which Dr. Vatsal has, and that would give you the Octa even in the periphery maybe, but I have no experience with that.
Deepti, if you had to buy, which one would you buy?
Ma'am, we already have a Heidelberg Spectralis, but the Optoview also has a great Octa, and that is perhaps a very good option also. Also, it is easier to use the Optoview as compared to the Spectralis that we have. Now, we are 2 or 3 people who know how to use the machine, but for somebody who is using for the first time or a new technician or optometrist, there is a slightly steeper learning curve for the Heidelberg Spectralis, as against the Zeiss or Optoview, which it's like a click and play. They can do it much easier.
Right. Dr. Rahul?
Yeah, madam, I had the opportunity to try the two machines, the Heidelberg. Given the chance, I would love to have Heidelberg, but there are certain limitations. Once it is little, it has a learning curve to do it. Not everybody assistant can immediately do it. So in the busy OPD, it takes time. Then the Octa is I think 9 by 9 window is available now, and also these many parameters are not given, like the density of vessels and FAZ. We have to use the third party some softwares to derive these values, which are available in the size Angioplex. And I would prefer Angioplex because it gives a wider Octa, and the post-sale service is better. And I'm already into the ecosystem of the Zeiss, so I will prefer.
It's just by natural this thing use, you would buy that. Dr. Nitin, what are you using?
I am using the Triton swept source. I think it's one of the earliest swept source machine. I think it's very easy to use, and the other advantage, it has a color image also coming with the B scan, that is OCT. So I think it's also a very good machine, and obviously the software of Spectralis may be a little better because Spectralis is laser based, but for a busy OPD, it's very quick and fast, and my technicians are able to get fairly good images. I think that's a good machine to think of. And now they have come up with a wide angle lens also, so you'll get a 22 or 24 scan with that machine also.
For Octa.
For Octa.
That would be nice.
Yeah.
And so that's an important tip.
Yeah.
And I think they are all in the little on the higher bracket.
Yeah.
Cost bracket. Even Triton, but
but for pachychoroid, Triton is a very good machine. You can easily pick up in all your routine B scans also. You can pick up pachychoroid well. So in the cases where you are on the border and younger patients with CNVMs, you know that it is mainly pachychoroid and not an AMD. So that is also very helpful.
Even in the dense cataract, it picks up very well. It's a swept source, so it gives better. Yeah, Triton.
Oh, that's great. So it was a great webinar. Any other questions, Manali, you have? I think we have taken all the questions which was asked. Yeah. How reliable is OCTA for CNV? Yeah, so one question I think we left behind. How reliable is Octa for CNV? you would prefer FFA or OCTA?
I think Dr. Muna has clearly mentioned it. Like it is not an machine. Octave is not a machine which will tell you about the activity. So if you will prefer to do an FFA, but FFA is invasive. So you first do an Octave if you get a good image and a good view, and if there is fluid or no fluid on B scan along with that Octave, then you will be able to decide what to do for the patient. But yes, FFA in certain situations will score over it, but being invasive, you will avoid it in many situations.
Okay. So I think we have asked all the questions which were on our Google form. Manali, you have any more questions to ask them?
No, I think we've covered. The lecture was
Covered all of it.
really,
It
covering
was
every aspect.
exhaustive. So basically, everything which people had asked, Dr. Munna had already covered. So thank you for that wonderful webinar. And my thanks on behalf of the Maharashtra Ophthalmic Society to Dr. Munna, Dr. Ashish Vaidya, Dr. Deepti Kulkarni, Dr. Nitin Prabhu Desai, Dr. Rahul Tiwari for sharing their valuable thoughts with us and sparing their time. And of course, to Ajanta Pharma for the sponsorship of this entire series, and Numerotrack for their technical support in arranging this program. So good night, everybody, till we meet again. And tomorrow we'll have revise and retain on Octa and FFA. All right. So good
Thank you.
night, everybody.
Good night, ma'am.
Bye.
Thank you.
Thank
Good night, Preeti.
See you
Thanks,
on Sunday,
Mona.
madam.
Thank you.
Yeah.
Bye.
Good night.
Bye. Bye.